Hello, my name is Guusje Elsen. I did my research as a part of my master thesis, and I did it at Utrecht. And it was about the research about spiritual needs, so it fits into what Eva just told. My research question was, how can an e-health module help mental health care patients to explore and formulate spiritual needs, which they consider important for their treatment and recovery? I used the methods that was an in-depth interview with 5 experts by experience from Utrecht. And I chose to interview experts by experience because they not only have their own views and meanings and way of seeing it, but also the meanings of their own patients, so that give a broader range of responses. It was a variation in gender, age, work experiences, which was also interesting, that it was people who were just starting to be expert by experience were a bit more reluctant, and some who were working longer as expert by experience were more open to also talk about it and have me into their conversation. So what I said, the group speaks from their own experience and also from the patients. I based my research on the chime. So Eva already said it a bit, but I will shortly take you through it so we can dive a bit into it. The first stands for connectiveness. This is mostly about peer support, relationship support from other and community. And there it also was really about having support from others and therefore also supporting yourself. Hope and optimism is focused on belief in recovery, motivation to change, hope inspiring relationships, positive thinking and valuing effort, and having dreams and aspiration. Here, it was also in literature a lot considered that it was a central factor in the chime, because it's a red line in all the factors. Identity is rebuilding positive sense of identity, overcoming the stigma. So with identity, it also was a lot about stigmatization, which is linked to it. Then you have meaning. This is meaning in mental health experience. It's also really about what you are feeling, what you see or what you went through, and giving the mental illness or experience a meaning really. Also meaningful life and social roles, and meaningful life and social goals. And the last, it's a bit difficult, I think, for you to see, but it's empowerment. And it is, I think it's really the last, how do you say, it's good that it's in the end, because you have to go through all these teams, I think, to have empowerment, because that's represent personal responsibility, control over life, and focusing on your strengths. So I use the chime as my building block really for the research. There's quickly just what I saw was that is there a changing landscape in the mental health care. I didn't really go too far into it, but I noticed that there is the personal recovery is really integrated in the personal movements of clients. So really recovery movement, but not per se in the medical view, which is still dominating, especially I think in the Netherlands. The primary focus of the interview was do the expert by experience recognize themselves in the chime teams, and do this team recur in the treatment? What meaning questions are these, and how and with whom do you want to discuss these questions? Does an e-health module help patients with this question, and does working individually with such a module provide enough insight in the questions that are important. And also, how can an EF module be helpful to identify these meaning questions, which may be relevant for treatment after? And at what point in the treatment could such a module be appropriate or useful? Selina also did the research about professionals about that, what we just heard, and I asked the patients. So that's you will see later in the results how that may differ from each other or not. And the secondary focus is there a need among outpatient clients for spiritual caregiver? The first findings, it was about general spirituality, and the respondents pointed out the importance of discussing these themes. So they really mentioned that chime is really important for recovery and should also really be integrated in the treatment. It was already mentioned by Eva, but again, you can see that there's some kind of reluctance, shame to talk about these spirituality needs or experiences. And especially if practitioners don't create the open space for it or don't really address these meaning questions, then patients will often not talk about it and keep them for themselves. So the holistic treatment model with the integration of personal recovery and meaning question is really wanted and necessary. One of the respondents answer, it's translated from Dutch to English, so it might not really be the same, but I try to really take the message out of it. You see that in treatment, more theories are applied, whereby the focus is less turned towards the meaning and recovery of mental health. The treatment barely touches the question, how do you cope? What has actually happened to you? What can you get out of it? So there's less room for your own development. And this is the part that was difficult to translate, but we focus on forcing the bird back into the cage instead of looking at why the bird flutters so much. And I found that really, because you have an image with it when you read it like that, and you can think, oh, that is a nice way to see it. What I found about the finding about chime was that the response have knowledge about these chime teams. They really recognize that they all play an important role in the treatment and recovery process. And by experience themselves, to really address them to their patients whom they're working with, but they do not have them with their own practitioners. So the experts by experience use them and discuss them, but they are not discussed in the treatment.
Do you mean by their colleagues, their professional colleagues?
Yeah.
Don't discuss.
Yeah, they don't discuss them. Yeah. And what I also found, and that was the one of the biggest result of the research, was that yes, the chime team or framework really incorporates the need and meaning of the patient, but there's a downside of it, and that is really the difficulties of all those teams, which was really addressed, because yes, we need connectiveness and it's a big team for patient, but let's also talk about loneliness and isolation. The same for hope. Yes, I want to have hope. I want to overcome this and have hope that that I'm gonna get better. But there's also the loss of hope and the despair. Really, the difficulty of not having the hope. Same for identity. Yes, I want to rebuild my identity. I want to try to really strengthen that part. But let's talk about the stigma also. The self-stigma that I inflict on myself, but also from the society that pushes me against your own illness and maybe pushes you away. Meaning, it's the same. You have meaninglessness and empowerment, whereby you see that there's, if you want to take personal responsibility, it's really, really hard if there's a stigma and if there's some kind of feeling sorry for yourself or also the victim being, if you see if there's victimhood. So it was really stipulated in the research and by the experts by experience that we have to take also into account the difficulties and the downsides of the CHIME teams. Then I found some results about the eHealth model, and they expressed that contact about the module with a peer group, therapist or spiritual counselor is the most important condition, because doing it individuality on your own is really, really difficult, and also maybe too much confronting. Because it asks reflection, it asks you about these questions of meaning, where you may have the downsides also experience the downsides of it. So yes, eHealth is a good option and is really helpful, but it should also involve a kind of contact, so with a peer group or with spiritual counseling. So the structure was they said that it should be nice if there were basic questions, CHIME teams, and but as a separate option, then you could also choose which team you wanted to address first. At what stage? Well, the patient needs to be stand open for it and have be not reluctant to engage in such a reflection module. But it's really, they said, not useful in the beginning stage. Like Eva also said with the research of Selina, when the treatment starts, it's too confrontational, and also it's maybe too heavy. So it could be better when the treatment already started. And also they said, don't make it a childish eHealth module, because then we're not feeling serious, because then it may be to do exercise that is really helpful for yourself, but it should also really be something that is not for child or so for too easy. And that was what the word they used. Don't have to be too easy. And the recovery journey of expert by experience serves as an example. But it should be more cut into the recovery phases. So really dive after each team, you have to have a separate option or module that you should engage in.
But you didn't tell, but there's one eHealth module from the Institution Parnassia, and all the respondents did it, yeah. And you talked about them with them about it.
So that's why they said that it should be more cut into phases. And then the findings on the need for spiritual caregiver among outpatients. There is the need to connect with peers and to participate into a spirituality, meaning, or mindfulness group with a spiritual caregiver. So again, the contact really is important, and the connectiveness with a group or somebody else is important. But it also really became clear that the role of spiritual caregiver is sometimes unclear. It's also really associated with religion and with more the religion part, and instead of being also just about life. So context should always be a free choice, and spiritual caregiver does not think from a medical model. That is what they said. So that could be a nice way to start a conversation, that you're really open and are there for them to listen to their meaningful questions. Conclusions. An eHealth module spirituality can thus be helpful to explore meaning, questions, and needs. The teams from the CHIME models fit, but we really have to also stipulate and mention and talk about the downsides, so the difficulties of these teams. What also came out was that the CHIME teams are especially Western oriented. So As a follow-up, it's interesting to dive into if spiritual needs of specific religion could or ethnic groups require more research, or if there is a difference in the results.
Non-Western patients.
Yeah. And the model should be used interactively. So I already said that there is a peer group could be an option. So that was my presentation.
Thank you, appreciate it.
Can I ask a question?
Ja, dan kunnen de mensen in de chat vragen stellen aan jullie twee.
Okay. Yeah. So, are there any questions?
Yeah. May I? Sorry. Hello.
Of course, and if you are planning to, so if you're also doing a follow-up research on the effects of this e-health module on, for example, these motivation and competencies of professionals, and also, of course, on the recovery of patients.
Yes, it hasn't been built yet because it goes step by step, and we are only a very small team. But we are trying to engage some students to do it for their master. It's not called Master of Arts and Communication, to help us, because we can give the content, but to do this really in a nice way, you need other designers. So I think we are going to try to first do one theme of the 5 CHIME themes and then test it in one department. And then so we will build on it, because it's a lot of work. We really want to know if it's helpful. Because we know from this Parnassia module, they designed it, I think 7 years ago or something. And it's in an e-health module house, they call it, where patients have their own access. But they don't know who is doing it. There's no contact with any person, and we don't want to do that. So we think we can do it slowly, and then we can see what the effect is of one theme, and then we build, and then we will also do follow-up research.
I think it's a nice suggestion to do the follow-up research, not only on patients, but also on the attitudes and the approach of the professionals. Yeah.
Yes.
Very interesting.
Yeah.
Yeah. There's interesting work. Congratulations. I think that training in approaching the spiritual dimension is clearly important. From what perspective should it be approached? Science, psychology, philosophy, anthropology. Are there any initiatives?
Nou, jullie lijkt me een vraag voor jou.
Wel nog even. Ja. Nee, om iets te vertellen over de training die we al aan de teams geven.
Oh ja.
En welk perspectief?
Ja.
Daar wordt het zitten wel.
Guusje, moet jij weer hier of niet?
Nou, dat gaat ook wel zo, denk ik. One of the initiatives we already did is designing a training in helping professionals to be more competent in spiritual care. And as I already told earlier, this training is more applied to the nurses and the expert workers than the psychologists and the psychiatrists. And you ask what kind of approach? Well, in this training, we find it important to keep this pragmatic and complementative approach together. And you ask for scientific approach. I think I would say like more a philosophy and existential approach is important there. Of course, I think it's also helpful for professionals when they have a scientific psychology view on spirituality and religion. But in this training, it's really about how can you address the topic with the patients? How can you make sure that it is part of the treatment? And then we use more this philosophical and existential approach. Is that an answer to the question, or?
But I would also add that all the time teams you can also do with specific.
I'm not sure if you will understand this because you're quite far from this microphone.
Also religion. Guusje said in her conclusions it was Western oriented, but I think we also have an imam at Althoff. I think he has to look at it too, because I think every chime team that can be developed also with religious themes in it. So I think this perspective has to be taken in it too when you train professionals, because chime is still I think Western and very wide, and we need also other, but you can relate these themes to religious themes too. Connection to God can be included very easily in the connectedness theme, for example.
So I think you would say that the theological perspective should be also included.
Yes.
Yeah. Any other questions?
No, not yet. Oh, yes. I think there is a difficulty in differentiating between the spiritual and the psychological in certain contexts.
Yes, it is.
And Michelle asked, how do you start addressing spiritual care interdisciplinary? How do you show the need in inpatient and ambulatory? Can you say it?
Ambulatory.
When it has never been addressed through care providers and peer support workers before.
Nou, het is niet nooit geadresseerd. Wil jij nou antwoorden?
The first thing coming up in my mind is the literature showing that the patients are not really likely.
Too far away, you have to go closer.
Yeah. The first thing which come up in my mind is the literature that shows that patients don't come up with the topic themselves so easily. So I think the first thing is that it is addressed and the questions are questioned to the patients. And your question is also about how do you it interdisciplinary. One part of the training I designed is also about how can you make sure as an interdisciplinary team that spirituality is discussed in a multidisciplinary overleg. Discussion and give some tools for it. And the tool I designed is based on the chime teams Guusje already showed. So this could be a place where you address the topic interdisciplinary.
Thank you.
Answer?
Is it an answer to your question? Or?
Yes, it does. I think.
And I cannot hear you, but I see you nodding.
I also want to add that when you develop a guideline, at a certain moment you also have to decide when do we refer to a spiritual counsel. That's not coincidental anymore. Because there are also questions that professionals cannot discuss with patients, and they have to refer them, and you have to decide at what point do you do that. So that, because now there's no guideline in that, it's often very, very much dependent on the affiliation of the professional, if they do so.
And then
we are having a discussion here. As if you can do this alone as a patient behind your computer, or maybe you need peers to discuss, because it seems like a process, and maybe you also need a
Yes, absolutely. Good question. I would translate the questions for the people here because I don't think they can hear you. The question out of the room is it possible for patients to reflect on spirituality by their own behind the computer without a human being to talk to? Shouldn't be there guidance or a peer group? And I think this is a question for you, right?
Yeah. Well, I will talk like this. I think that what it was also stipulated in the research is that people really need that contact with a peer group or a spiritual caregiver or a mindfulness group or some interaction. But I think they also mentioned that you can have the best is to have both. So and the contact, so and discuss it in a group, but also to do it on yourself, because then you have more time to reflect maybe, and also have more time to really ask yourself these questions also, because sometimes you have to think about something yourself, and then you have more reflection to discuss it. So it came up that it is necessary to discuss it also with peer groups or a group, but it's also really good to do it on your own if you're capable and willing to.
Yeah. I also have an additional question, because I work in a FACT team. It's a community team as a psychiatrist, and one of the important things about kind of team is that every colleague knows the patient very well, so we can give help together or improve or better. I don't know how to say. Okay, so but when you do the e-health module, and only have a peer group or one partner to speak about your spirituality, then it's not around all the colleagues of my team.
Yeah.
So I think spirituality is one of the most important things we do.
Yeah.
So that's a problem.
Yeah, you want it to be integrated fully in the treatment and not something separate. Is this what you say?
Yes.
Yeah, okay. Yeah, I think that's very important too.
But we thought of exploring one theme, and at the end of one theme, formulated by the patient, what is important for me in this theme to communicate with my practitioner, so that they can think themselves, reflect first themselves, what do I want to share and where do I want my help? Because there's also some recovery and personal recovery outside mental health care. So you can also discuss it with your parents or with friends. But that you have after every theme a moment of reflection, because the purpose is to discover the questions that are important for treatment for you. For the patient, they have to discover the questions that are important for themselves.
I think that's a discussion. I really want to know the whole patient.
Yes.
That's what's really
but if he or she is willing to share everything, they can do it.
But it can also be, you can use the e-health module to also start a conversation with you and your patient. So it can just be a handout or something to help you to know the whole patient. Then,
well, you want to ask something, but it's also time. But
three.
Yeah. So we will answer can we answer the questions in the chat later?
If this goes down, you can also in the Hoover app open a chat question. That's possible afterwards, but this one closes down.
Yes. Okay. So we.
There's a break now, so you have time to answer the question. I will answer them now.
Okay.
Okay.
But I will maybe close the session here. So we can go to the coffee. And
we will answer in a minute or so your questions.
So the question is just what you asked about the combination of the FACT and on the other hand the chat room, and on the other hand the e-health. Where comes the spirit protocol perhaps in? With Rosemary, it's possible to integrate that in this.
We are thinking about this. Yeah, absolutely. Yeah, if the sync is very possible. Because the management team says make an e-health module, but for us it's also quite a question how to do spirituality in a computer, right? Yeah. So I think the spirit program gives way more options.
Already there. The spirituality is already there.
Yes. Thank you so much for
the
nice interaction.
For sharing.
The first question was about how do you differentiate spirituality and mental health care outcomes? How do you define the difference between spirituality, existential, psychological concepts? Well, that's a very complex one actually, and Christopher Cook talked about it yesterday, and also Eva Ouwehand wrote something about it in her PhD. So maybe this question is for you.
Well, I think spirituality is a very broad concept, and I don't think we can talk already about outcomes. We talk about that patients really say that they need discussion about spirituality in their treatment. But we are not so far that we can say this also for hospital chaplains, which interventions will be effective. Because I think we are only at the beginning of that to do empirical research in our profession. So I think psychologists are very much used and psychiatrists to work with measurable outcomes, but spiritual caregivers are only in the beginning stage. And I think as to this e-health module, this is a thing over time. When we have tested it on different departments and use it for a longer time, then we can start some research about what the effect of it is. And then you compare, for example, outcomes dependent on, because most mental health outcomes are according to diagnosis, whereas a spiritual care module or group usually is with people with different diagnoses. So I think that's still a long way to go. I don't know if you agree, but
yeah,
it is.
You did a fine work on making a foundation.
Yes,
but it's the beginning.
Yes.
Yeah, in my thesis, I wrote some conceptual difference between spirituality and existential and psychological well-being, but it is the translation to the practices is difficult and still in the beginning. Yeah.
And I think also it's not always possible to separate.
No, there will be there's a lot of intertwining.
I think it's also in recovery-oriented care, it's very difficult to measure the outcomes. I think that's the same question as about spiritual care, because you need outcome measures that are more personally tailored and not only the reduction of symptoms, for example, of feelings of well-being. So this is a whole research subject we are developing in the coming years, I think.
Mm-hmm.
David Rosman defined the spirit program as effective just on the people telling that they profited from it.
Mm-hmm.
So that's also an outcome. Yeah.
Yes.
Yeah, that is.
Yeah.
Yeah, and maybe this also brings us to the next question. What kind of assessments would you recommend? Well, there are some different assessments, but for me, I find like the spirit is maybe the most helpful. We are trying to make a tool by Chime, but we didn't test the outcomes yet, so we couldn't say anything about that at this point. But I'm also interested, what kind of assessments do you already know and think about yourself?
Maybe. Welke ben je aan het antwoorden?
Ja, deze eerder. Kan niet meer scrollen. Deze.
Yeah, this one.
This one I tried to answer.
So that was for Michelle. Yeah. And then, yeah.
We go to the last question.
It's also for Michelle. That's not for you.
Nou, daar weet jij meer van. Suicide.
Yeah. Yeah, I think there's a few literature on suicidality, especially if there's a possibility of using religious and spiritual interventions. There's nearly no literature on it on this theme, as far as I know. But I think it's very interesting and promising to add to regular interventions also interventions that give people a new connectedness to sense of meaning, all these giant themes. Because that is also what people need when they want to get out of their suicidality or problems.
You can unmute yourself, Michelle, if you want to talk now.
Can you hear me?
Yes.
Okay, great. And can you see me?
Yes, it's nice to see you and hear from you.
So nice to see you both. Yes, that really does help answer the question. because I know we have to start, at least in nursing, we learn to start with an assessment, right, of what do people need, what do they want, what do the nurses, like, how do they think that integrating spiritual care can be done in a reasonable way with everything else they have to do, right? So I think that's really helpful. And there's so many interventions that connect people to sense of meaning and whatnot. So I think even research in those interventions that can be done on inpatient or ambulatory, there's just so much area, like so many different interventions and research to be done on what this looks like in different settings. So, but yeah, so did you want me to ask my other question, or I had written it in the chat there?
I think we missed it then. Can you repeat it?
Can you repeat it?
Yeah, so one thing I've learned from my research is that literature shows that spirituality and religion help to decrease suicide rates, use rates, and depression rates. So do you find that this justification helps to integrate spiritual care into mental health care for individuals who have diagnoses that have a higher risk of suicide, such as bipolar disorder, borderline personality disorder? Do you find that being specific to diagnoses or to help with suicide prevention has been a good incentive for spiritual care?
Yeah, I think it's Bart van der Brink here. I was also already a bit in the discussion, but I think it's important to integrate in the treatment. But the question you ask is, does integration help to decrease the rates of suicide, decrease the rates of substance use or depression? But then you have to do it in a preventive fashion, and that's not thus far possible to design a program and to give many patients such an intervention and to see if they become less frequently depressive or less frequently suicidal. But happily is a less frequent outcome. But I don't know literature on these themes if this is possible to prevent such outcomes.
And I think that the main justification is not only in the outcomes, but that the recovery movement says, and patient want it. That's what Rosmarin told yesterday too. I mean, we are crazy if we don't do it because we can see it helps. He says he has really done quantitative research, but I think for us in the hospital, chaplains don't do very much quantitative research, but the justifications lies in that patients say regular care is not enough for us. We are a whole being and we want to be addressed as a human being in our whole, in all life domains. So I think that is justification. In the Netherlands, I think this is also the pressure that came from the patient movement, that now in all mental health care hospitals, there are experts by experience who work there and are paid and have to follow some education. And they really talk with other patients about this, about spiritual care, but all the CHIME teams, because they know it by experience. So I think the justification for all what we do is that patients say, help us with this. Mm-hmm. And this is enough research. There is enough research to say that there are spiritual needs and they are not met. Yeah. Or not met enough. And then you have to make a choice what you're going to do because there are many options.
Yes, I agree. There is also literature out there on the benefits of spiritual care and spiritual strategies and spiritual psychotherapy. Yeah. I think for me, an area where I've worked as a nurse in acute care, where spiritual care was just not, it wasn't a topic that, it wasn't something that nurses really did unless they felt compelled to address spiritual topics because, they were the same religion as the patient or they felt comfortable to talk about existential questions with the patient. So I always looking for strategies to start integrating spiritual care more into the mental health care. So thank you for your work and for all of the discussion. It's been very...
And doing research yourself, also as a nurse, this is very effective too. Because when you are in an institute and you do research yourself, you naturally talk about a lot of people with it, and you have to, to connect to people about it. So that has a certain consequence in development as a by effect of doing research.
Right. Yes. Thank you. Yeah.